This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2014, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Pulmonary Function Test Quality in the Elderly, a comparison with younger adults. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I am pleased to welcome Mr. Gregg Ruppel. Mr. Ruppel recently retired from his position as the Director of the Pulmonary Function Lab at St. Louis University Hospital in St. Louis, Missouri, and currently holds an appointment as Adjunct Professor in Pulmonary, Critical Care, and Sleep Medicine at St. Louis University School of Medicine. Neither Gregg nor I have conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Gregg, welcome to the program.
Thank you, Shauna, and thanks to everyone for coming in to participate this afternoon. Hopefully the topic for discussion here will be something that will be of interest to many of you and will also be something of practical importance to your everyday practice. The research question is pretty clearly stated in the materials in the paper itself, and I think it's always important to make sure that somewhere in the introduction to the paper that the author does specifically state that. Along with the research question that they're trying to answer, it's usually important to frame this in the context of a null hypothesis, or what is the thing that we're trying to prove or disprove. So again, as stated here, the research question is, can elderly patients achieve quality scores for spirometry and DLCO comparable to a younger adult population? And if we were to express that as a null hypothesis, it might be stated something like, there is no significant difference between the acceptability and repeatability for spirometry and DLCO between older adults and younger adults. And so we'll kind of focus back on that as we look at the methods and then also when we look at the results. Why this particular topic is important is that both of these tests, spirometry and DLCO, have elements of patient effort and cooperation. So as those of you who are familiar with PFTs know, the patient must be willing and able to cooperate, and the technologist must elicit a maximal effort, or at least a reasonable effort during most of these tests. The second thing is that spirometry and DLCO have significant evidence-based indications in the evaluation of lung function. That means they're important for understanding basic physiology and, by extension of that, to managing the underlying diseases. So spirometry and DLCO are two very important tests that we need to be concerned about. And then lastly, as you're all aware, the population is aging, and so we need to be prepared to deal with elderly subjects, and there may be differences between how they perform the test and how younger subjects perform the test, and that's exactly the topic of this paper. In the introduction, the author goes through some background literature which is discussed more completely in the discussion at the end of the paper. I'm going to deviate from that a little bit and talk a little bit about the background literature kind of as the introduction, and then we'll look and see what this particular author did and found in relation to that. In the references in the paper are really the first 11 references in the reference section. And one of the things that several of the references point out is that The mini mental state examination, or MMSE as it's abbreviated, is used to grade cognitive impairment. And so this is kind of a standardized test that looks for signs of dementia. It includes arithmetic and orientation, and I think there's 30 items in the test. And then in terms of scoring the test, individuals who score above 24 or 24 to 30 are considered normal or have normal cognitive function. 18 to 24 have some mild decrement in their function, and less than 18 or 17 a severe impairment. And so the couple of studies in the references clearly point out that patients that do have cognitive dysfunction as identified by the MMSE have difficulty performing spirometry. And that's probably what you would expect. It doesn't really relate to their age, but if they have cognitive dysfunction, then it makes sense that they're going to have difficulty performing the test. Those first 11 references also contain a few papers that suggest that elderly subjects who don't have cognitive dysfunction can perform acceptable spirometry. And again, these were done by administering the test of cognitive function and spirometry to the same group of individuals. It's interesting to note that the acceptability and repeatability of spirometry ranges kind of all over the place depending on which particular parameter you're looking at. So FVC might be different than FEV1, but the ranges of acceptable spirometry in elderly subjects appears to be somewhat similar to what we see in the general population, and that is they range anywhere from around 70 to 95% of subjects being able to perform acceptable tests. As you might guess, the FEV1 tends to be more repeatable in the elderly. And if you think about this for just a moment, it makes sense that the FEV1, which comes early on in the procedure, the forced exhalation, if you will, is something that even elderly subjects who may have some impairment are able to perform. And it tends that this occurs much more frequently than their ability to repeat the forced vital capacity maneuver, which obviously takes longer and is more subject to variability. So just as we see in the general population, the FEV1 tends to be more repeatable. But that being said, most of the papers that are referenced by this author suggest that age all by itself doesn't appear to be a limiting factor. And so that would suggest to us that, yes, in fact, there should be no significant difference between what a elderly subject can do and what a normal adult of a younger age might be able to do as well. The other thing I think that's important to note is that misdiagnosis of both COPD and asthma is common, not only in the elderly population, and there are a couple of references to make that point, but in the general population as well. And you may be aware that the misdiagnosis of COPD resulting from the fact that the patient may not have had spirometry performed is around 40%. That is, in a large study done in the Veterans Administration a few years back, they found that only in some areas did 40% of individuals who carried a diagnosis of COPD actually have spirometry. And asthma is probably similarly neglected when it comes to performing spirometry. And in fact, a recent recommendation of what should be done from the American Academy of Allergy and Immunology suggests that asthma shouldn't be diagnosed without spirometry. So it kind of makes sense that it's important to get good quality data, and the misdiagnosis of COPD and asthma is going to be at least as common in elderly subjects as it is in the population in general. Finally, the background literature looks at a couple of studies of DLCO, and the references aren't directly related to elderly subjects, but rather looked at DLCO in a couple of large populations of individuals. And what they found was that it's not very well documented. In fact, one of the studies suggested that people who are younger may actually have a more difficult time performing the DLCO maneuver simply because of the inability to inhale an adequate volume, what we refer to as the maximal inspiratory vital capacity. It's also important in the context of this paper to realize that some of these references relate back to studies that were done 10, 15, or even 20 years ago, and that the criteria for DLCO and spirometry were slightly different at that time. I think it's also important to recognize that when the term elderly is used in some of these papers, it's not often defined, and in some parlance it's anyone over the age of 65 is considered to be elderly. However, the elderly population in this particular paper is very well specified, and it's somewhat different than may have been used in the past, in that it included only older individuals. So let's look then at what I consider the most important part of any published study, and that is, how did the author go about getting the results? And that falls into the methods section. So we'll spend a couple minutes looking at this. This was a retrospective review, and that means that the data had already been collected, and then the author of the paper decided to go back and look at the data retrospectively. The study could have been done prospectively. That is, they could have set out and at one point in time began to collect data and collected data until a certain number of data sets were collected. But in this case, probably doesn't make a lot of difference, and it may actually have been of some benefit to do a retrospective study so that there was no influence or bias from those participating in the study, knowing that the study was ongoing. In other words, all of this data was collected under normal laboratory conditions, and then it was only evaluated after the fact. And so, as the author points out, they looked at all of the patients tested. They didn't exclude any patients, and they defined two groups. The elderly was defined as anyone 80 years of age or older, and again, that's somewhat different than what you might find in other papers in the literature talking about the elderly, where 65 or 70 is used as the cutoff for elderly. And they used a control group, which they defined as adults 40 to 50 years of age who were referred to the lab. So again, this is a retrospective study rather than prospective, but I don't think that is a detriment to the study itself. The sample size that was acquired is really depending on how far back the authors looked. And again, a retrospective study makes this somewhat easy because you can look backward until you have a large enough size sample that you think will fulfill the requirements of the study. The authors note that a post hoc power analysis was done. Power analysis is usually a question that's asked of a prospective study in which the investigator wants to know, how many subjects do I have to test in order to detect a certain amount of difference? The post hoc power analysis is something that's somewhat controversial in the statistical literature in that it's looking at data that's already been collected and trying to decide whether or not an adequate number of subjects were enrolled. And we'll come back to this when we look at the results. And then sources of bias. The source of bias that probably would be of most concern would be that all of these patients who were included in the study were referred to a hospital laboratory. So it wasn't a random sample taken from the population in general, but rather these were all subjects, elderly and ages 40 to 50, who for one reason or another were referred to a PFT lab to get a pulmonary function study because of some reason that the referring physician thought that it was indicated. So that's a little bit different than a randomized trial that is drawn from a general population. And of course, it's important to keep in mind that because of that, it's likely that some of these patients had abnormal pulmonary function tests. So we have a mix of patients who have both normal and abnormal lung function. The methods go on to describe the data quality measurements that were in place during the time that the data was collected. And as you look down this list, what you should see is that the items listed here pretty much describe an ideal quality assurance program for a pulmonary function lab. That is, they adhered to the ATS/ERS 2005 recommendations. They used software that graded the quality of the tests that were performed. The tests were overread or looked at by an additional layer of individuals, in this case the chief technologist, and that the lab the lab QA program included feedback to the technologists who were performing the program. That's probably one of the more important aspects of quality assurance in the pulmonary function lab, is that the technologists continually get feedback from someone who's reviewing their work in order to make sure that they are, in fact, doing all of the things that are expected from those 2005 recommendations. Last but not least, the laboratory used equipment quality control, including biologic controls, to make sure that all of the equipment was functioning within its design limits. The predicted values that were used you may not recognize, because these were the GLI, or Global Lung Initiative, predicted values, which were just published formally last year, or in 2012, excuse me. These were a large set of predicted values that were generated by the European Respiratory Society under the auspices of Philip Quanier, and included data from individuals who were healthy, non-smoking subjects from ages 3 to 95. And so the fact that the GLI predicted set includes patients all the way up to age 95 makes it particularly useful for this type of test, where we're looking at the data from elderly subjects. And the author used reports both a percent predicted and the lower limit of normal. That's important, again, because remember, one of the questions when we talk about the quality of the data is, if some of these patients had abnormal tests, were the elderly subjects more likely to have abnormal tests than the normal subjects? And so that's kind of an additional question that this data set out to identify. As a point of reference, these are a couple of graphs from the Global Lungs Initiative predicted sets. And what's being described here, and let me just try to point to these, on the graph you see the lower limit of normal, that is the lowest fifth percentile for these normal healthy females and over here males, but the lower limit of normal being expressed as a percentage of the predicted value. And what you should notice is that the widely used criterion of 80% of predicted really only fits the data from about age 20 up to about age 40 or so in females, and similar in males. The variability in older subjects tends to be much greater and to fall off, so that using percent of predicted in subjects who are 80 years old or older can be very misleading, because the lower limit of normal would suggest that the abnormality doesn't really begin to exist unless the percent of predicted is 65 to 70% of predicted. And you can see that that's true in both males and females. So again, the statistical methods that were used for the Global Lung Initiative predicted set allow us to account for that in the data by using the percent of predicted. And so that's a fairly important phenomenon, and we'll kind of refer back to that when we look in the results section. Finally, in terms of statistical methods, the the paper identifies which methods were used. For the categorical data, that is data which has an either-or type of answer, male or female, elderly or younger, the Fisher's exact test was used, and this is commonly used for contingency tables. For the continuous variables, that is the FEV1, the FEC, the DLCO, two tests were used. One was the student t-test for unpaired means, and the other was the Mann-Whitney U-test. And it was used to compare medians. And if you think back to your high school statistics, when we take the mean of a number, we simply take the average, but the median is the 50% point, and so in sets of data that have a lot of outliers, it's very important to look not only at the mean but at the median. And so these two tests were used in order to make statistical comparisons whether or not the data was evenly distributed or whether there were some outliers in the data. And you'll see later on that there really weren't a lot, but that's a good approach to take. So again, the data is reported as the mean plus or minus the standard deviation. And for the median, they reported the interquartile ranges, or the 25% ranges above and below that median point. It's important to realize that a two-tailed type of analysis was applied here because we're not sure whether the elderly subjects are going to have values that are greater than the younger subjects or less than. And so we have to consider both tails of the distribution. And again, the authors point out that they used a post hoc power analysis, and we'll discuss that as well. Figures 1 and 2 from the paper simply show you an example of how the software that was used in the lab went about assisting the technologists to achieve high quality data. And this particular software lists the possible things that can go wrong during spirometry in terms of acceptability of the maneuver as well as repeatability or reproducibility of the maneuver. And so for each maneuver that the patient performed, the software allows the technologist to go back and look at the data and see whether or not all of those ATS-ERS criteria have been met. And so you can see here green check marks for the pre-spirometry results and red check marks for the post-spirometry results, showing that at least 3 acceptable maneuvers were performed. The 2 best FEV1s and FECs were within acceptable limits for repeatability. So again, this is a tool that the technologist uses during the course of the test in order to make sure that good quality data is collected. The second figure shows also that a similar approach was used for selecting whether or not adequate DLCO maneuvers were performed. So again, this is the data that was then used to go back and look to see whether or not these individuals performed acceptable and repeatable pulmonary function tests. And again, using this kind of feedback tool during the course of testing allows the technologist to make adjustments on the fly. That is, if the first 2 maneuvers are not acceptable, then the individual can perform additional maneuvers until the acceptability and repeatability criteria have been met. So let's look then at the results. And the first results that are available are the demographics describing the populations that were involved in the diagnosis of the data, evaluation of the data. So you can see that there were 150 subjects who were 80 years of age or older, which is a fairly significant number of elderly subjects. And for that same time period, the control subjects numbered 178. And so when we look at the various parameters describing the 2 groups, you can see that the mean age for the elderly folks was 83.9. And that's the average, and the median was almost identical to that. So whether we look at the mean or the median, we get very similar numbers, and you can see that for the control group, the values are very similar as well, telling us that the mean and the median were not significantly different, suggesting that there weren't a lot of outliers in either of these groups. As you might expect, there couldn't be a lot of outliers in the elderly group, and this was a pretty well-defined group of ages 40 to 50. And so it's not surprising that the p-values, remember p-values reflect the probability that this value would be obtained purely by chance. And so the p-value here being much less than 0.05 suggests that these differences are not by chance, but they're by design. Of course, the design was to have two groups that were significantly different in age, and the p-values here would suggest that that was in fact accomplished. There were about 52% females in the elderly group and 60% females in the control group. Again, that was a difference that didn't reach statistical significance. In other words, it's not less than 0.05, it's slightly greater than that. And in terms of ethnicity, you can see that there was only one non-Caucasian individual in the elderly group, and there were about 10 non-Caucasians in the control group. So again, there are very small differences between those two groups, but they're statistically significant, less than 0.05. But for practical purposes, we can say that each of these groups was largely Caucasian ethnicity. The next table looks at the spirometry results. And again, what the authors are showing us here is that were there differences between the spirometry measurements and the DLCO measurements between the elderly subjects and the control subjects? So if we look first of all here at the FVC percent of predicted, you can see that the mean percent of predicted and the median are very similar, and in the control group they're quite similar as well. However, the elderly group's percent of predicted is significantly lower than the control groups for both the mean and the median. And on the face, this would suggest that the elderly group had significantly lower FVC percents of predicted than the control group, suggesting perhaps more disease or more abnormal pulmonary function. However, because the authors used the GLI predicted set, which provides the lower limit of normal and accounts for that variability that expands in elderly subjects, as I've showed on the previous slide, you can see that when the number of subjects who fell below that lower limit of normal, who fell into the lowest 5th percentile, when that was compared between the two groups, there was no significant difference, suggesting that the level of abnormal pulmonary function between the elderly and the control subjects, based on a statistically valid lower limit of normal, was not significant. And again, you can see a similar pattern in the FEV1 percent of predicted. If we simply look at the percent of predicted, it appears that the elderly group is significantly lower than the control group. However, when we apply the approach of looking at the lower limit of normal, there was a non-significant difference between the two groups, as you can see from the numbers. Finally, when we look at the FEV1 over FVC ratio, which is the hallmark of obstructive lung disease, we again can see by comparing it to the lower limit of normal, only about 20% of the elderly subjects and 22% of the control subjects would be classified as having obstruction of some degree. And so again, the p-value suggests that that's a non-significant difference between those two groups. So again, there were some individuals who had obstruction in both groups, but as chance would have it, the two groups turned out to be fairly similar, hence no significant difference in the p-value. The authors then looked at the DLCO results in pretty much the same fashion. Again, the mean and the median were similar in both the elderly and the control group. However, the elderly group's percent of predicted was significantly lower than the control group, suggesting that there were more individuals with reduced DLCO by the p-value of less than 0.001. However, when we looked at the DLCO below the lower limit of normal, a similar pattern emerges. That is, that there were a significantly larger number of individuals who fell in that below the lower limit of normal than in the control group. And this would suggest that, in fact, the individuals in this particular study did have a lower DLCO compared to the control group, even though, as we've seen from the previous slide, their spirometry values tended to be much more similar. Keep in mind, however, that the lower limit of normal for the DLCO is based on an equation in which the lower limit of normal is calculated from 1.65 times the standard deviation of the normal healthy population, or the standard error of estimate, if you will. Because that's a fixed number, the lower limit of normal tends to stay constant even as you apply the equation to elderly subjects. What we now know, and what you should remember from the previous slide that I showed from the GLI data, is that in elderly subjects, there's much more variability than we see in healthy young people ages 20 to 40, where the lower limit of normal is close to 80% of predicted. So even though the lower limit of normal was used here, it may not completely explain what appears to be a significant difference between these two groups. But there certainly is a difference in terms of the DLCO results. Finally, we get to the key slide here, and that is the slide which scores the individuals in these two groups as to how well they performed in terms of their spirometry and DLCO quality. So again, for the spirometry grades, the software that was used assigned a grade of A to those individuals who had both acceptable and repeatable spirometry. And in some instances, there were individuals who didn't have quite as good of a quality spirometry, and so they achieved either a B or a C grade. And you can see that adding those few individuals in here, including individuals who got only an A grade or got anything greater than a C, and comparing the elderly and the control subjects, the p-values for those two groups are well above 0.05, suggesting that there's no significant difference between these groups in their ability to achieve acceptable scores, whether you look just at the people who got everything perfectly or those who didn't do quite as well, but produced data which was likely usable for clinical diagnostic purposes. So again, in answering the question as can elderly subjects perform spirometry as well as younger adults when referred to a hospital pulmonary function lab, the question here is yes, they can, and the answer to the null hypothesis is that we can't reject the null hypothesis. In other words, if the null hypothesis was there's no significant difference, we can't reject that based on the probability of obtaining these data purely by chance. For the DLCO quality, we see similar results. We have a group where all standards were met, and the p-value there is well above 0.05. And there were a couple of individuals who performed the main parts of the test procedure correctly, but failed in one or two other of the criteria. And you can see here there was just one individual here and two individuals here, and if they're included in those groups because that data is clinically useful, again, it doesn't make a significant difference. And again, we would have to reject the null hypothesis or accept the null hypothesis that there's no significant difference between these groups. So again, this is kind of the key findings that we're interested in from this particular paper. Looking then again at the results, the most common reason why both the elderly and the controls failed to perform acceptable spirometry was inability to continue exhalation for at least 6 seconds, or to have a back extrapolated volume, which we abbreviate here as BDV, greater than 5%. Now, those of you who perform spirometry know this means that the patient needs to exhale forcefully and continue exhaling for 6 seconds. The back extrapolated volume is really a measure of whether or not they leaked out any gas into the spirometer before beginning the forced part of the maneuver. And again, those are two reasons for failure were seen in both the elderly and controlled subjects. The most common reason for DLCO test failure in these two groups was not specifically stated in the paper, but in talking to the author of the paper, I learned that the inability to inspire at least 85% of the best vital capacity was the reason for failure in those individuals who were unable to perform acceptable maneuvers. So again, these are things that we see in the population of folks that show up for pulmonary function in general, and I guess we shouldn't be surprised to learn that there's not much difference in elderly subjects, at least in those who don't have cognitive impairment. The results also talk a little bit about post hoc power analysis, and as I indicated earlier, this is somewhat controversial among statisticians because power analysis is generally used for prospective studies, not for retrospective. And the question would be, once you've obtained the data, and if the data doesn't show a significant difference, as is the case in this study, the question becomes, well, did we look at enough individuals, or did we have enough subjects in our study to detect a significant difference? The problem is that looking retrospectively, and particularly looking at things like pulmonary function variables, we many times don't have a good handle on what is a significant difference. And so it becomes difficult to say whether or not a significant difference has been observed when, as we've seen in the previous slides, the statistics suggest that there weren't any significant differences. So again, post hoc power analysis would suggest that, yes, these tests were powered adequately to detect a level of difference, but the level of difference is hard to determine, particularly when we look at it after the fact. So to kind of wind up, under discussion, the important things related to why this study is important is that underdiagnosis, overdiagnosis, and misclassifications are all problems related to the elderly, and there's a couple of references in the reference section to support that. As is the case, not performing spirometry is the problem that most often relates to these types of problems where the patient's diagnosis is missed or an incorrect diagnosis is made. As you probably are aware, asthma and COPD are common problems not only in the elderly but in children and adults as well. And most asthma is diagnosed from clinical signs and symptoms, and many patients who are diagnosed with COPD have that diagnosis applied without the benefit of having spirometry performed. So what we can conclude from the data that's been gathered from this study is that elderly patients without cognitive impairment can perform spirometry and DLCO acceptably and reproducibly. What this study adds to what we knew before is particularly for patients who are older than 80 years of age, this study certainly supports the concept that these individuals can perform spirometry and more importantly, DLCO, which hasn't been evaluated very much, just as well as their younger counterparts. I think it's also important to point out that the quality assurance program that was in place in this particular lab probably had a lot to do with the ability to achieve acceptability and repeatability values that were in the 80 to 90% range, some of them above 90%. And so again, those high levels of data quality pretty much require that you adhere to the current ATS guidelines and utilize a laboratory QA program like that described in the methods section of this particular paper. It's also, I think, important to realize that data from patients who don't score a perfect test, many times that data is usable as well for making a diagnosis, and that's particularly true of the FEV1. So even patients who are unable to perform an acceptable, repeatable forced vital capacity maneuver many times can perform an acceptable and repeatable FEV1 maneuver, and that's data that can be used to manage their disease process. So that's an important takeaway message as well. No study would be complete without talking about potential limitations, and so there are some sources of bias that you need to keep in mind when you think about the results of this study. Most of the individuals were Caucasian, and so it's entirely possible that trying to apply the results of this study to other ethnicities might produce different results. As I've already noted, the hospital lab referral was the pattern by which patients were admitted to the study, the assumption being that someone thought that they needed a pulmonary function test, and so their level of lung dysfunction may have been higher than a general random sample from the population. And in fact, I'm sure that it was. The individuals in this particular study didn't have their cognitive impairment evaluated, so there was not a direct relationship between the level of cognitive impairment and their ability to perform acceptable and repeatable spirometry. But again, as the numbers would suggest, likely that there weren't a large population of subjects with cognitive impairment simply because 90% of them were able to perform acceptably. Again, different results might have been obtained using different equipment, particularly if the other equipment didn't grade the software didn't grade test quality as comprehensively as the software that was used here did. And again, the technologist's skill, experience, and motivation is always a key factor. And again, in this case, the quality assurance that was applied in the lab tried to make sure that the technologists were well motivated by giving them feedback. The take-home message then is elderly subjects can perform acceptable and repeatable spirometry and DLCO similar to their younger counterparts, and that the comprehensive lab QA program is likely to contribute to high rates of acceptable tests. And last but not least, that the predicted sets that are selected need to be done so in a careful manner, particularly if you're evaluating elderly subjects. And that's because some of the older predicted sets that are available didn't include large numbers of healthy elderly subjects, at least subjects over 80 years of age. And so that can become a significant limitation if you find yourself in a situation where older subjects are being tested. There is an editorial that accompanies this particular paper in the issue of Respiratory Care, and that was from Helen Sorensen, and she brings out several different points, two of which I thought were particularly important, and that is that misdiagnosis and misclassification of asthma and COPD in older subjects can be reduced by good quality PFTs. Not to belabor the point, but I think it's important to remember that you have to do PFTs in these elderly subjects, and you have to realize that by using good quality assurance techniques, you can obtain high quality data even if the subjects are over 80 years of age. And last, she points out that because of some of the changes in healthcare reimbursement that have occurred in the last year or so, a lot of hospitals are being scrutinized for readmission of patients with COPD because that will affect whether or not they get reimbursed. And so anything we can do to provide better diagnostics for those patients should help improve that particular aspect of disease management. I think that's an important point to make. And so I'm going to stop at this point and be happy to spend a few minutes trying to address any questions that have arisen.
Thank you, Greg. This was a great session. I appreciate it. There are several questions, and we have a few people who are interested in the demographics of the sample size. So the first question is, due to the lack of racial ethnicity, how translatable is this study's data?
That's a very good question, and as I pointed out in the section talking about potential limitations, it's difficult to generalize when you don't have a population or a sample population that represents the population in general. So while this study probably represents the population statistics in the area of Vermont where it was done, it may not be generally applicable across the United States or in other countries. So again, it doesn't mean that elderly subjects of other ethnicities would necessarily perform less well, but we can't make the assumption that they would perform as well or better without actually testing it.
So do the authors give any explanation as to why so few minority subjects were represented in this study?
I suspect that because of the referral patterns of their particular hospital, that's probably representative of the population that they normally see. Now they could have either retrospectively or prospectively made a point to include a number of individuals of other ethnicities, but that might have meant that they would have had to extend the length of the study back further in time or farther into the future in time for a prospective study in order to make sure that there was adequate representation of various different ethnic groups.
Thank you.
This is one of the drawbacks of doing prospective studies is the data is what's there. And so you're sometimes limited because of things like lack of diversity in ethnicity.
Thank you. That's important for us to remember about the prospective versus the retrospective designs. We have a question about the GOLD criteria. How does GOLD justify using fixed cutoffs for diagnosing and grading severity if it is so bad in the population that we're dealing with, mostly people in their 60s and up?
Yeah, that's a very good question as well. If you're familiar with the GOLD criteria, you know that they use the FEV1 % of predicted to grade severity, and anyone with a FEV1 less than 80% of predicted is considered to have moderate obstructive impairment if their FEV1 ratio is also reduced after bronchodilator. That's the exact problem that I tried to allude to during the presentation of the slides, and why it's so important to look at the lower limit of normal rather than the % of predicted. Because the variability in these parameters increases in the elderly, and not just the elderly, but in individuals over about 40 to 50 years of age. The variability in these parameters in healthy subjects increases markedly, similar to what we see in pediatric subjects. And so we need to take that into account. And so using a fixed cutoff like 80% for moderate or 50% for severe, the way the GOLD guidelines do, those are pretty much the points that seem reasonable to the committee of scientific experts that represent the GOLD committee, but they can be biased because, as we know, variability changes in elderly subjects. So again, I always try to make the point that the lower limit of normal is better. And of course, the ATS-ERS guidelines, particularly the guideline that talks about interpretation, suggests that we should use the lower limit of normal rather than a fixed cutoff percent of predicted, if at all possible.
Thank you. There is a question about the GLIA predicted, the values that you spoke about that was published in 2013. This participant says that one problem we have in the U.S. is a lack of consistency of predicteds. Since the GLIA have introduced their reference values for spirometry, many manufacturers are incorporating them into the testing units. When and how can we get our physicians to use them? When will the GLIA DLCO equations be available?
Okay, well, there's two parts to that question. The GLI spirometry equations are available, and as the questioner pointed out, most of the vendors are now getting up to speed and getting the lookup tables that are required to use the GLI predicted sets, getting them into the software. So you shouldn't be surprised if you see that those predicteds are available. How to get people to use those predicteds, I think you have to educate the physicians and the individuals who are responsible for deciding what predicteds are used in a particular laboratory setting. You have to educate them about why these predicteds are preferable to some of the older sets that have been used so commonly in the past. And the biggest reason that I can think of is that the statistical methods used for the GLI predicteds included statistical tests that account for the variability that I showed on that one slide, particularly the increasing variability with increasing age. As far as the GLI predicteds for DLCO, that's a project that has just been started recently, and again, it's going to be much more difficult to gather predicted DLCO values from healthy normal subjects representing almost all ethnicities around the world. So that's an ongoing project that's underway, and I'm not sure that there's a clear end point in sight as far as when those might be available. Individuals who are interested in finding out more about the GLI predicted sets, how they were derived, and why they should perform better than older predicted sets, can go to www.lungfunction.org. That's all one word, lung function, and read all about it there.
Gregg, thank you again for joining us today. This has been great, and I typed the website into the chat box for anyone who wanted that, www.lungfunction.org.
Good. Great.
So, Gregg, thank you for joining us. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.